Before I begin, I need you to hear this clearly. Everything I share in this video is for educational and informational purposes only. It reflects current research and ongoing clinical debate in cardiovascular medicine. Nothing I say here is medical advice, and nothing in this video should be used as a reason to change, reduce, or stop any prescription medication. That decision belongs to you and your physician, and only to you and your physician. With that understood, let's talk about what may be happening inside your body right now. I want to open with a number, not a blood pressure number. Not yet. The number I want you to hold in your mind right now is this. Approximately 36 million falls happen every year among American adults over the age of 65. 36 million. Falls are the leading cause of injury death in that age group. They are the single most common reason older adults lose their independence permanently and irreversibly. And here is what I need you to understand before we go a single step further. A significant portion of those falls are not accidents. They are happening because of a drug, a small pill, prescribed with the best medical intentions in the world that is quietly, systematically doing something in the aging body that the guidelines used to prescribe it were never fully designed to account for. I'm Dr. David Thompson, cellular longevity specialist and cardiovascular architect, and what I am about to share with you has been building at the edges of cardiovascular medicine for years. A landmark analysis published in JAMA Internal Medicine, drawn from one of the largest cardiovascular trials of the past decade, has forced a fundamental reckoning with how we treat blood pressure in adults over 65. Some physicians have begun to integrate it into their practice. Most patients over 65 have never heard it, not because their doctors are hiding it, but because the system moves slowly, and because no one has explained it in language that actually protects you. I am going to give you a specific target range today. The real number. The number the evidence associates with the lowest mortality in older adults. But I am not going to give it to you in the next 60 seconds. And I want to be honest about why. If I give you the numbers now, you will write them down, feel informed, and close this video. And you will do that without understanding why those numbers exist, without understanding what happens when pressure is pushed below them, or whether your individual biology means your target should be adjusted. Context in cardiovascular medicine for older adults is not a nice to have. Context is the difference between a longer life and a catastrophic fall in the dark. If you are 65 or older or watching because you care for someone in that range, type two things in the comments right now: your age and your current blood pressure numbers, if you know them. Now, I want to tell you about Eleanor. Eleanor was 78 years old, and she was, without any hesitation, a model of active aging. She lived alone in the house she had shared with her husband for 41 years. She drove herself to book club every Tuesday. She maintained a vegetable garden started from seeds every spring. Each morning she walked 1.5 miles through her neighborhood. She wasn't training for anything. She was moving every day under her own power, with full intention. Eleanor had been living with a blood pressure that hovered around 148 to 152 over 85 to 90 for most of her late 70s. She had been on a moderate dose of a calcium channel blocker for about 6 years. Well tolerated, stable, no significant side effects. Her kidneys were stable. Her cognitive function was intact. She still completed the New York Times crossword every morning before her walk, in pen. Then Eleanor changed primary care physicians. The new physician was excellent, rigorous, genuinely committed to evidence-based medicine, and the evidence-based standard, systolic blood pressure below 130, ideally approaching 120, for most adults with cardiovascular risk factors, was the standard she had trained on and believed in. She reviewed Eleanor's chart, saw the gap, and made the decision the guidelines were designed to prompt. They started optimizing. A second antihypertensive agent was added at a low dose. Eleanor noticed dizziness when she stood from her chair, a brief swimming sensation that would clear after a few seconds. She mentioned it. Her physician documented it. They decided to give the regimen more time to settle. By January, Eleanor's blood pressure was reading 124 over 76. Her physician was genuinely pleased. The numbers were exactly where the guidelines said they should be. Eleanor stopped driving herself to book club, not because anyone told her to, because she no longer fully trusted herself behind the wheel. There was a subtle unpredictability to how she felt when transitioning from sitting to standing that had begun to make her nervous. The vegetable garden didn't get started that spring. Then came the night in late March. It was approximately 2 in the morning. Eleanor woke needing the bathroom. She sat up, she stood, and the blood, delivered at a pressure nearly 30 points below what her body had spent 8 years adapting to, did not reach her brain fast enough. Her baroreceptors, the tiny pressure-sensing organs in her carotid artery walls, had aged. They were slow. The reflex that should have tightened her vessels didn't fire the way it once would have. Eleanor fell. She caught the nightstand on the way down. The impact fractured her left hip, a trochanteric fracture requiring surgical repair. Her daughter found her the next morning. She had been on the floor for several hours. The surgery went as well as could be expected for a 78-year-old. But the combination of anesthesia, surgical stress, prolonged immobility, and systemic inflammation that follows major trauma in an older body is a biological cascade that geriatric medicine still struggles to interrupt reliably. Eleanor developed hospital-acquired delirium. She required a skilled nursing facility for rehabilitation. She never went home. The deconditioning that happened in those weeks, the loss of muscle strength, balance, and cardiovascular endurance she had built through years of morning walks, happened with a speed that still arrests me. The pneumonia came 6 weeks later. Eleanor's daughter called me not long after her mother's death. She wasn't looking to assign blame. She kept saying, "My mother was fine. She was walking every day. She was doing the crossword in pen." What happened? What happened to Eleanor is not a tragedy born of negligence or bad medicine. Eleanor's physician was doing exactly what she was trained to do. What happened is a tragedy born of a guideline designed for a population that does not fully include Eleanor, being applied with full fidelity to a body it was never designed to govern. And Eleanor's story is not rare, not even close. To understand why this happens, and why the target numbers I'm going to give you are what they are, you have to understand 4 biological realities that change how the aging cardiovascular system operates. The first is arterial stiffness. Your arteries are not passive tubes. In a young, healthy vascular system, the walls are elastic. They expand as the heart pushes blood through them, absorbing the pressure wave, then recoil to smooth blood flow between heartbeats. As we age, elastin degrades and is progressively replaced by collagen, a stiffer, more rigid protein. Think of it this way: young arteries function like silicone tubing, flexible, resilient. Aging arteries behave increasingly like copper pipe. They transmit the pressure wave instead of buffering it. And critically, your brain, kidneys, and heart muscle all receive blood at the end of a pressure gradient. When you artificially reduce source pressure in a system that has already adapted to operating at higher pressures, you reduce perfusion to all those organs simultaneously. If the vessels are already narrowed by decades of atherosclerosis, even a modest pressure reduction can be the difference between adequate and inadequate flow to the organs, keeping you alive and cognitively intact. The second is baroreceptor desensitization. Baroreceptors are mechanosensitive neurons in your carotid arteries and aortic arch. They detect pressure changes and relay that information to your brainstem in real time. When you stand, gravity pulls blood downward. In a young person, the baroreceptor reflex detects this almost instantly and triggers a rapid compensatory response. Heart rate accelerates, peripheral vessels constrict, blood pressure is restored before the brain ever registers a deficit. In older adults, that reflex has been progressively blunted by cellular aging. The sensors are less sensitive, the response is slower. When a 78-year-old on 2 antihypertensive medications stands up at 2 in the morning, the system that should protect them is already compromised, and the medication has pushed the baseline pressure to a level where no physiological buffer remains. When those two things intersect in the dark, the math becomes catastrophic. The third is altered pharmacokinetics, and this is almost never explained to patients. As we age, both liver and kidney function decline. Glomerular filtration rate, the standard measure of kidney filtration efficiency, decreases progressively after age 40. Hepatic enzyme activity declines alongside it. The practical result, the same dose of a blood pressure medication that produces a well-calibrated effect in a 50-year-old may produce a dramatically stronger and more prolonged effect in a 75-year-old. The drug doesn't know the patient has aged, and this means the older adults at highest risk from medication-induced hypotension are often those who have been on the same medications the longest, precisely the patients whose kidney function has declined furthest from where it was when the dose was originally set. The fourth biological reality is the most important for understanding how risk calculus changes with age. Cardiovascular harm from moderately elevated blood pressure is a long-term risk. For a 45-year-old, a sustained systolic of 155 represents a meaningful increase in heart attack or stroke probability over the next 20 to 30 years, a risk worth treating decisively because there are decades for the damage to compound. A 78-year-old is operating in a fundamentally different risk landscape. The time horizon is shorter. The competing risks are larger and more immediate. And critically, the risk of a fall in a hypotension-vulnerable older adult is not a long-term statistical probability. It is a present, concrete danger with a mortality trajectory that can unfold within hours of a medication adjustment. Eleanor did not die of elevated blood pressure. Eleanor died of what happened to her blood pressure at 2 in the morning when the medication meant to protect her long-term took away the physiological buffer she needed to survive that night. Now I want to talk about the evidence, because this is not just a clinical argument constructed from first principles. The SPRINT trial, one of the most influential cardiovascular studies of the modern era, examined whether intensive blood pressure lowering to below 120 systolic produced better outcomes than a standard target of below 140. The cardiovascular benefits were real and meaningful, but SPRINT had critical exclusion criteria. Patients with significant dementia were excluded. Patients with prior stroke were excluded. Patients with advanced kidney disease, systolic heart failure, or institutionalized residents were excluded. The frailest older adults, those most likely to be harmed by aggressive pressure lowering, were not fully represented in the data that produced those targets. When researchers specifically analyzed SPRINT participants aged 75 and older, published in JAMA Internal Medicine, the picture became considerably more nuanced. Yes, cardiovascular benefits were present in that older subgroup, but rates of syncope and serious falls were also significantly elevated in the intensive treatment arm, and when those 75 and older participants were stratified by frailty status, the benefit to harm balance shifted dramatically. The frailest patients showed the smallest cardiovascular benefit and the greatest harm from intensive pressure lowering. The people the guidelines were meant to help were, at the extremes of frailty and age, being harmed by their application. Subsequent large observational studies have consistently identified what researchers describe as a J-shaped relationship between blood pressure and mortality in adults over 75. Not a linear relationship where lower always means lower risk. A curve where the risk of death is lowest within a particular range and rises on both ends. The bottom of that J-curve across multiple large data sets consistently falls between 130 and 140 millimeters of mercury systolic. Not 120, not 115, 130 to 140. That is the longevity sweet spot, and that is a number that looks very different from what many older adults are currently being told. The European Society of Cardiology, whose hypertension guidelines are among the most rigorous in the world, explicitly advises against pushing systolic pressure below 120 in any older adult, recommends a target of 130 to 139 for adults aged 65 to 79 where tolerated, and acknowledges that less intensive targets may be appropriate for frail elderly patients, building individualized frailty assessment directly into the treatment decision tree. That is mainstream cardiovascular medicine in Europe. It should be mainstream everywhere. Let me make this concrete with 3 clinical scenarios. Harold is 72, active, golf twice a week, light resistance training, no significant fall history. His kidney function is excellent for his age. His frailty score places him firmly in the robust category. Harold's blood pressure tends to run around 134 to 138 over 82. His cardiologist reviewed the full picture and made a deliberate decision to leave those numbers where they are. Harold's organs are perfusing well. His brain is sharp. His kidneys are stable. Treating Harold to 120 would produce, at best, a marginal statistical reduction in long-term cardiovascular risk, while introducing fall risk, potential kidney underperfusion, and quality of life degradation. The cardinal principle: do not fix what is not broken, and do not create a new problem in the pursuit of a number. Margaret is also 72, but her profile is different. She had a myocardial infarction 5 years ago. She has type 2 diabetes, which substantially elevates her baseline vascular risk. Her kidneys show early-stage chronic kidney disease. For Margaret, The presence of existing cardiovascular damage and diabetes shifts the risk calculation meaningfully. A target around 130 systolic is appropriate, but the path to that target must be slow, incremental, and continuously monitored for orthostatic changes, calibrated against her kidney function and positional blood pressure variability, not just against what her cuff reads in a clinic at 10 in the morning. Ruth is 83. Ruth uses a walker. Ruth has had 2 falls in the past year, both fortunately without fracture. Her kidney function has declined significantly. She scores in the moderate to high frailty range. Ruth's blood pressure tends to run around 155 to 162, and Ruth's geriatrician has made a specific, deliberate, documented decision. She is not chasing a lower number, because for Ruth, the next fall is not a statistical abstraction. It is the most concretely likely next catastrophic event in her life. The medication required to move Ruth's pressure from 158 to 130 would substantially increase her syncope risk, her fall risk, and her risk of the cascade that took Eleanor. Ruth's physician chose Ruth, not the number in Ruth's chart. That is cardiovascular medicine done with integrity. I want to hear from you right now. If you are over 65 or a caregiver for someone in that range, type "treating the patient" in the comments. If you or someone you care for has ever experienced dizziness or that swimming lightheadedness when standing up, type "dizzy." That symptom has a name, it has a mechanism, and it matters more than you may have been told. Before I give you what you can act on today, I want to briefly address what I consider among the most underappreciated consequences of pushing blood pressure too low in older adults, something that reaches into the brain itself. The human brain consumes approximately 20% of the body's total cardiac output. It has autoregulatory mechanisms to maintain its own perfusion across a range of driving pressures, but that autoregulation has a lower limit. And in the aging brain, particularly one that has accumulated vascular risk factors or white matter changes, the autoregulatory curve shifts upward. The minimum pressure required to maintain adequate cerebral blood flow is higher than in a young brain. Studies examining cerebral blood flow in older adults have found that lower diastolic blood pressure is independently associated with greater white matter lesion burden, small areas of vascular damage that correlate with cognitive slowing and, over time, with increased dementia risk. There is a pattern appearing with increasing frequency in geriatric practice. Older patients presenting with apparent cognitive decline who show measurable improvement when their antihypertensive regimen is carefully and deliberately reduced. I am not telling you blood pressure medication causes dementia. I am not telling you to stop your medication. What I am telling you is that chronic, low-grade underperfusion of the aging brain from mismatched blood pressure targets is a hypothesis with growing biological plausibility and growing clinical support, and it belongs in every conversation about blood pressure management in adults over 70. Now let me give you something you can act on today. The first thing I want you to do is a test you can perform at home right now. It is called the orthostatic blood pressure assessment, and it will show you whether your current regimen may be placing you in the fall risk zone. You need a reliable upper arm home blood pressure cuff, not the wrist style, which is less accurate for this purpose, and a timer. Step 1. Lie flat on your back for 5 full minutes of complete rest. Then, without getting up, take your blood pressure. Record systolic, diastolic, and pulse. Step 2. Stand up as you would getting up in the middle of the night, promptly, without a long preparation sequence. Take your blood pressure within 60 seconds of standing. Record it. Step 3. Remain standing. Take your blood pressure again at the 3-minute mark. Record that reading. What you are looking for: a drop of 20 or more millimeters in systolic pressure or 10 or more in diastolic between the lying reading and either standing reading. That is the clinical definition of orthostatic hypotension. If you find it, bring those 3 readings, with exact times noted, to your next physician appointment. That appointment should include 6 specific things. First, bring a genuine blood pressure log, a 2-week record of readings at different points in the day: morning before medication, mid-afternoon, evening. Clinical decisions should be based on a pattern, not a snapshot from a clinic visit. Second, bring your orthostatic test results. If you found a significant positional drop, your physician needs that information. Third, ask whether your blood pressure target has been individually calibrated to your frailty status, fall history, and kidney function, or whether it reflects a population-level guideline that may not fully apply to your biology. Fourth, if you are on more than one blood pressure medication, ask whether the combined regimen has been reviewed against your current kidney function. Function changes over time. Dosing should be recalibrated accordingly. Fifth, ask about your dosing schedule. Some antihypertensive medications produce their peak pressure lowering effect during overnight hours, precisely when bathroom fall risk is highest. Evening dosing of certain agents warrants specific discussion. Sixth, and ask this clearly and without apology, given my age, my functional status, and my fall history, has my blood pressure target been individually calibrated to my biology, or is it following a guideline developed for a broader population? That question, asked with respect and specificity, will tell you a great deal about how your cardiovascular care is being delivered. You have the right to that conversation. You have the right to a target built around your body, your vessels, your kidneys, your baroreceptor response, your specific risk landscape, not around the statistical median of a clinical trial population. I want to close by coming back to Eleanor. Her daughter kept describing her mother with the same images. The crossword in pen, the morning walk, the vegetable garden started from seeds, and she kept asking, what happened? Eleanor's story is not an argument against treating blood pressure. It is not an argument against evidence-based medicine. It is an argument for blood pressure treatment that is faithful to the whole individual receiving it. Medicine that examines the complete architecture of a person, their age, their frailty, their kidney function, their fall history, their functional life, and constructs a treatment plan around those realities, rather than bending the person to fit the plan. The numbers I have given you today, 130 to 140, as the longevity zone for most adults over 75, with adjustment toward 130 for robust individuals in the 65 to 74 range, and adjustment upward toward 150 and beyond for significant frailty. Those numbers exist because that is where the outcomes data says older bodies survive and function at their best. You are not the average. You are a specific human being with a specific vascular architecture, a specific history, specific risks, and a specific future that deserves to be protected with specific, individualized, biologically faithful care. Independence is not something youth bestows and age simply withdraws. Independence is an architecture. It is built, maintained, and defended. It requires decisions, vigilance, and knowledge. The kind of knowledge that puts the right questions in your mouth the next time you sit across from a physician who is genuinely trying to help you. If this video reached you today, share it with every person you know who is over 65 or who is responsible for someone in that range. The person who most needs Eleanor's story may not be the one watching right now. If you haven't subscribed, please do so now. Every piece of content we produce here is built on the same commitment, rigorous, research-grounded, unapologetically protective of senior health and the independence that makes life worth living at every age. In the comments, I want one word before you go. If Eleanor's story affected you, if you recognize someone you love in her, or if you are leaving this video prepared to have a different conversation with your physician, type legacy, because that is what Eleanor left, not a tragedy, a lesson, one that does not have to repeat. I'm Dr. David Thompson. I'll see you in the next video.